to start this speech.
Thank you so much, and I thank Vidikon for giving me this opportunity to facilitate. My topic is to deal with some controversies related to a very common disease, subclinical hypothyroidism. I will try to see whether we can arrive at some consensus in the various issues. So this is the agenda I am going to go through today. Let us start with the first one, that is the journey of subclinical hypothyroidism. So it has been evolving since last 5 decades, and it was initially called in 1973. And in 1976, Nielsen had made a very interesting observation, a philosophical observation. The subclinical hypothyroidism is an example of impact of technology on the concept of disease. That means it depends on how you are measuring your pHs, and that's how you arrive at a definition of subclinical hypothyroidism. Because only pHs which changes, nothing else changes. There will be no specific clinical criteria to diagnose subclinical hypothyroidism. I'll come to that. So the previous assays have been changing. You can see here. Initially, the lowest limit for detection was 5, and now we have 0.01 with CLI, cavity emission assays, very sensitive and with high precision. And because of this lowest detection limit, we now have a lot of people who we can actually exactly identify what is the pHs level, and that leads to a diagnosis of subclinical hypothyroidism. So, what is a pHs reference range? Again, for any population reference range, you have this distribution curve. It's called Gaussian distribution, where the mean value is in the middle, and you have a spreading out like a inverted bell. Okay, and the right side and the left side, the extreme cases are actually taken as the 97th centile on the right side, and the 3rd centile or 2.5 centile on the left side. Within that, we consider that as normal. But for pHs, there are some interesting observations. For example, there will be some euthyroid outliers. That means some people may have high pHs like 6 or 7, but they can actually be euthyroid. And there could be some autoimmune thyroid disease where your pHs could be absolutely normal, but they may have autoimmune thyroid disease going on. So this is somewhat fallacious. That's why it's very important, and we have to be very careful in actually making a diagnosis of subclinical hypothyroidism. This is actually a big NIHANES, and hence so-called study where they had done a survey of more than 13,000 patients, where they found that the mean value for their population who are negative for thyroid antibodies, who didn't have any family history of diabetes, and who didn't have any goiter. So all confounders eliminated. The mean value was around 1.12. So 2.5 to 97 percentile was 0.45 to 4.12, and mean is 1.4. So that's how we are now having the assays. So why you call this range as a normal? Because this is because of these studies, for this particular study. There's few other studies. For example, these Korean studies had a mean value of 1.82 and median value of 1.62. And another study from Swedish population, it was a little bit skewed towards left. The mean value was around 1.2. We did a study, so-called Guwahati Thyroid epidemiological study. Ours was a little bit shifted to the right. The mean value for male was 2.1, and for female it was 2.1203. It's a little bit similar. So we are slightly on the right side of the mean value what we have found in the Western literature. So what is this definition of subclinical hypothyroidism? What is the epidemiology? So it is characterized by serum pHs above the upper reference limit in combination with normal free thyroxine. We all consider 4.2 or 4.5 at the upper reference limit. But your free thyroxine or total thyroxine has to be normal. Generally, you can diagnose this as subclinical hypothyroidism. In case your THS is coming above 10, probably it is dangerous to diagnose that patient as subclinical, because that patient may be actually harboring a clinical thyroid disease. Of course, if your repeated T4 levels are normal, that patient still can be considered as subclinical hypothyroidism. This designation is only applicable. So, what are the confounders? When thyroid function has been stable for weeks or more, recent fluctuation may give a fallacious result. The hypothalamo-pituitary thyroid axis is absolutely normal, and there is no recent ongoing severe illness, because we all know there is something called non-thyroid illness where THS and T4 levels, either T3 levels can go away. So we have to wait for the recovery from the illness, then repeat the test after 4 to 6 weeks and arrive at the destination. So what is the prevalence of subclinical hypothyroidism? Actually, it's very interesting. Subclinical hypothyroidism, if you take the cutoff of 4.2, it is higher in case of younger population, lower in case of younger population. For older population, it is higher. So pHs rises according to the age. Every decade there is a rise in pHs. So if you consider 5 or 6 as abnormal for a young person at the age of 35, that may not be normal, that may be absolutely normal for an 80-year-old person, and this has got huge implication on your treatment, because you should not try to treat elderly population with subtle rise in pHs that might cause some damage.